The session will start in 10 minutes. Please take your seats and silence your electronic devices.
This is how you remind me of what I really am. This is how you remind me of what I really am. It's not like you to say sorry. I was waiting on a different story. This time I'm mistaken for letting you a heart worth breaking. And
Welcome to the Health Innovation Summit. The session will start in 5 minutes. Please take your seats and silence your electronic devices.
Now put your hands up in the club. You just broke up. I'm doing my own little thing. You decided to dip, and now you want to trip. 'Cause another brother noticed me. I'm up on him, he up on me. Don't pay him any attention. Just crying my tears, get 3 good years. You can't be mad at me. 'Cause if you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. Don't be mad once you see that he want it. If you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. Don't be mad once you see that he want it. If you like it, then you should've put a ring on it. I got gloves on my lips, a man on my hips, got me tighter than my dairy on jeans. Acting up, drinking my cup. I can care less what you think. I need no permission. Did I mention? Don't pay him any attention. 'Cause you had your turn, and now you're gonna learn what it really feels like to miss me. 'Cause if you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. Don't be mad once you see that he want it. If you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. Don't be mad once you see that he want it. If you like it, then you should've put a ring on it. Don't treat me to these things of the world. I'm not that kind of girl. Your love is what I prefer, what I deserve. Is a man that makes me, then takes me and delivers me to a destiny, to infinity and beyond. Pull me into your arms. Say I'm the one you want. If you don't, you'll be alone. And like a ghost, I'll be gone. All the single ladies, 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 all the single ladies. Now put your hands up. Cause if you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. Don't be mad once you see that he want it. If you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. If you like it, then you should've put a ring on it. Don't be mad once you see that he want it. If you like it, then you should've put a ring on it.
I'm bringing sexy back. Yeah. The mother boys don't know how to act. Yeah. I think it's special what's behind your back. Yeah. So turn around and I'll pick up the slack. Yeah. Take 'em to the bridge. Dirty babe. You see these shackles, baby, I'm your slave. I'll let you whip me if I misbehave. It's just that no one makes me feel this way.
Take it to the chorus. Come here, girl.
Go ahead, be gone with it.
Come to the back.
Go ahead, be gone with it.
VIP.
Go ahead, be gone with it.
Drinks on me.
Go ahead, be
See
gone
what
with
you're
it.
twerking with.
Go ahead, be gone with it.
Look at those hips.
Go ahead, be gone with
You
it.
make me smile.
Go ahead, be gone with it.
Go ahead, child.
Go ahead, be gone with it.
Get your sexy up.
Go ahead, be gone with it.
Get your sexy up.
Go ahead, be gone with it.
Get your sexy up.
Go ahead, be gone with it.
Get your sexy up.
Go ahead, be gone with it.
Get your sexy up.
Go ahead, be gone with it.
Get your sexy up.
Go ahead, be gone with it.
Get your sexy up.
Go ahead, be gone with it.
Get your sexy up.
You ready? You ready? You ready?
I'm bringing sexy back. Yeah. Your mother your eye attack. If that's your girl, better watch your back. Cause she'll burn it up for me, and that's a fact.
Take her to the chorus. Come here, girl.
Go ahead, be gone with it.
Come to the back.
Go ahead, be gone with it.
VIP.
Go ahead, be gone with it.
Drinks on me.
Go ahead, be
See
gone
what
with
you
it.
twerking with.
Go ahead, be gone with
Look
it.
at those hips.
Go ahead, be gone with
You
it.
make me smile.
Go ahead, be gone with it.
Go ahead, child.
Go ahead, be gone with it.
Get your sexy out.
Go ahead, be gone with it.
Get your sexy out.
Go ahead, be gone with it.
Get your sexy out.
Go ahead, be gone with it.
Get your sexy out.
Go ahead, be gone with it.
Get your sexy out.
Go ahead, be gone with it.
Get your sexy out.
Go ahead, be gone with it.
Get your sexy out.
Go ahead, be gone with it.
Get your sexy out.
You ready?
Yes,
You ready?
yes, yes.
Welcome to the Health Innovation Summit. The session is about to begin. Please take your seats and silence your electronic devices.
It's better than yours, I could teach you, but I have to charge. My milkshake brings all the boys to the yard, and they're like, it's better than yours, damn right. It's better than yours, I could teach you, but I have to charge. You want it, the thing that makes me, what the guys go crazy for. They lose their minds, the way I whine. I think it's time. La 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 la. Warm it up. La 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 la. The boys are waiting. La 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 la. Warm it up. La 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 la. The boys are waiting. My milkshake brings all the boys to the yard, and they're like, it's better than yours. Damn right, it's better than yours. I could teach you, but I have to charge. My milkshake brings all the boys to the yard, and they're like, it's better than yours. Damn right, it's better than yours. I could teach you, but I have to charge. On it.
For more than 100 years, Novo Nordisk has been driving change. What have we learned? Helping to improve lives must go hand in hand with improving health and well-being. That people are more than their disease. That's why we have spent more than a century developing treatments to help people live lives less limited by their disease. A century of pioneering scientific breakthroughs in key areas. Today, we lead the way with transformational initiatives aimed at creating better treatments and a better world. Like you, we do it for the people who are living with, thriving with, and not being held back by disease. They are why we are investing in new, innovative medicines, why we are continuously expanding our offerings, why we are working toward an even brighter future. It's why, through the Novo Nordisk Foundation, we support scientific, humanitarian, and social programs. We are, and will always be, committed to driving change, to fight for the people living with, thriving with, not held back by disease. We call them the Greats, because their disease doesn't define them. So what will? Novo Nordisk, driving change. Learn more about how Novo Nordisk continues to drive change by scanning these QR codes.
Hey, no running in the halls, Nico. My bad.
Good afternoon. Once again, please welcome to the stage NCQA Senior Communications Advisor, Andy Reynolds.
The moderator of our final panel this afternoon is a senior vice president who leads a large department at NCQA, the department that, from many perspectives outside the company, is NCQA. And that's because they've got good team spirit. No, that's because Lori Ferguson and her staff in product and customer operations are the deciders. They are on the front lines working with other organizations, deciding who meets NCQA standards and therefore who has earned NCQA accreditation, certification, and recognition. Now, before Lori joined NCQA, she led the transformation of a Medicare Advantage plan that raised its quality ratings from 3 stars to 4.5 stars. And many of you in this room can appreciate that's hard to do. Another thing about Lori that makes sense to share with you in Nashville on a Friday night is she's been to this town many times on more than one bachelorette party. So if you need a tip about where to go tonight on Broadway, Lori Ferguson is a great person to know. I'll have Lori tell you about her panel, but please welcome Lori Ferguson.
Thank you, Andy, for that very colorful introduction. I have been looking forward to this discussion, and if you're wondering why, then just take one look at the gentleman that has just sat next to me on this stage. All 3 of them are quality trailblazers, and each in their own way really walk the talk when it comes to elevating quality and value-based care, and they got outcomes to show for it. Let me tell you a little bit more about each of them. To my immediate right, Daniel Kuzmanovich, Managing Director and Expert Partner at Advisory Board, focused on providing highly vetted research on the biggest issues keeping healthcare leaders up at night, like value-based care. Dr. Farzad Mastashari, co-founder and CEO of Aledade, the nation's largest network of independent primary care practices in the country. Former National Coordinator of Health IT at Department of Health and Human Services. Welcome. And Wilson, at the end, Gabbard, Vice President of Quality and Condition Management for Advocate Health, the 3rd largest not-for-profit integrated health system in the United States and a national leader in population health. Prior to that, he spent 7 years leading population health operations for UNC Healthcare. Thank you all for being here. Let's jump right in. So there's a lot of energy around value-based care. We've been saying that for probably over a decade. Maybe we're just hitting the tipping point, right? And any day now. Just by a show of hands, how many people have worked in some way on forwarding value-based care in the last 12 months, 18 months? Yeah. No lack of energy. Look at that. That's more hands than any panel has raised in their questions, I think, so far in the last 2 days. But I think the progress is a lot slower than many of us would have anticipated 10 years ago. So we're going to talk a little bit about why that is today, but why is it so important, despite some of these setbacks and the slower than expected progress, that we continue with all these hands and all the folks across the nation working on value-based care to drive this forward? Daniel.
I think progress is the first place we should start that. If you were to go back to 2015 and use HCP land data and say, okay, how far in 2015 were we on a journey towards value-based care? The data would tell you that we were kind of at a 60-40 split. And if you were to look at that same data today, it's probably going to change next week when it comes out. But the data would tell you today that we're now more at a 40-60 split. We have made a ton of progress in kind of 20 percentage points in a 8-year period of time. That's nothing to laugh at. But I think the fact that we have had to try so many different models. We have tried from CMS, they have created, I think at this point in time, 60 different models of value-based care. About 30 of them are still operational. 6 of them are eligible for expansion. 4 of them have saved costs. 2 of them have demonstrably improved quality. So on the idea of progress, it has been a difficult road, but it is super important to continue, because what other choice do we have? If we look at the population of the United States of America, what used to happen to 65-year-olds is now happening to 45-year-olds. We are getting sicker, and I think that the important word about progress is we actually have made some steps. I think just earlier this week, the Medicare Shared Savings Program, MSSP results came out, and $2.1 billion with a B dollars were saved to American taxpayers through that one model alone. So progress, yes, it's been hard, but I think we have to continue just because what other choice do we have?
You know, Alidade accounted for what, a third of that, Farzad?
We are happy to serve.
It was a third, maybe more than a third.
It's interesting looking at the Medicare Shared Savings Program, and many of the CMMI programs that you mentioned that did save money did so by increasing participation in the Medicare Shared Savings Program. So I think it's worth us saying, what is it that makes that program successful? And it is giving accountability to total cost and quality to primary care physicians. I think we still have a lot more work to do on how do we properly incentivize specialists, but when it comes to primary care, and that's what Alidade focuses on, if you look at the data, there's very high penetration, like 90% penetration of engagement in the Medicare Shared Savings Program or other ACO programs by the largest practices, health systems, big multi-specialty, like 90% plus are participating already. Where we see lowest participation, it's like absolutely tied to practice size. So it's the smallest practices that have the lowest rates of engagement and participation. And you can imagine why. They lack the size, right? In order to be able to have a risk pool on their own, you need to have a way to bring people together. Disparate practices who have not worked together before have to come together. There's a trust factor there. There's a data, technology, coaching, playbook. You need all of that, and that's what Alidade is built to do, is to help bring those groups together. But once you do that, you see that they can actually perform on value-based care at a very, very high rate. And I hope we can get into what is the work on the quality side involved in that may be somewhat different than when you have a large, organized system with, control over all aspects of care.
Wilson, have you ever seen one of those?
Yeah, no. Have you? I remember Farzad said something to me a couple years ago. It's like, anyone who thought they could control a physician, something along those lines.
I did say that.
Farzad, so, but no, I think, and I mean, Farzad hit on the primary care front, and as a former clinic operator and primary care, diehard, I think it's absolutely imperative. But, living in the health system space, I think it's critically important that, I think about the two most successful value-based programs, Medicare Advantage and MSSP, in my opinion, are, the antithesis maybe of the fee-for-service mechanism, right? But even for systems like ours, who are really bought into value, we have 2.3 million lives in a value-based arrangement over, I think, 111 current count of value-based contracts across our 7 states, and it still makes up a pretty small percentage of our total revenue. And so I do think that there's still a misalignment when we think about why it's not going faster. I do think the payment mechanism is still not completely aligned, and the vast majority of the payment is still in the fee-for-service model.
Can I share a statistic? We crossed a milestone. 10 years in, practices who started with us, some of them literally 9 years ago in Delaware, they this year made more money from shared savings than they did on fee-for-service for their Medicare patients.
That's progress.
That is
That's
awesome.
progress. Let's talk a little more about the incentives, right? So if you've ever talked about value-based care, it's really simple. You align incentives, you align measurement, and you get value, right? Why isn't that easier? Farzad.
I think our practices are not purpose-built around a very narrow segment. And you mentioned Medicare Advantage, and many of the groups that were really successful were purpose-built to take care of Medicare Advantage seniors. And that's not most of the world we live in. Most of the world we live in is you have a practice with a panel that has all sorts of payers on it. And you mentioned having we also have hundreds of contracts, but there's also huge portions of the panel that are not under value-based care. And we have not seen, and this is a plea for help from our health plan colleagues out there, on the commercial side, we have not seen the same sort of sustainability in the value-based constructs. They're still where the Medicare Shared Savings Program was in 2012, where you got ratcheted almost immediately. If you got savings, now your benchmark is lower. If you get savings, now your benchmark is lower. So I would say one of the hardest things of creating that alignment and that winning the hearts and minds is being able to do it across a bigger part of the panel.
Yeah, great point. Wilson, other thoughts?
Well, Daniel and I were chatting about this, backstage, not actually related to this topic, but to your point about ratcheting, I think the other problem, I oversee the risk adjustment work for our system, and the inconsistency of, the financial equation in value-based care. It is so varied, especially across our commercial payers, and I'm sure many of you all can resonate as well. But I mean, we have, I want to say 111, I think, value-based contracts. There are 107 as of this morning. I went, when I was prepping my notes, to check on the spreadsheet across all of our contracts, 107 unique measures that represent, more than 1,000. I couldn't get a discrete count of how many unique or how many total measures across those we had in contracts. But it's just, you think about, that's just the quality side of the equation, which I'm sure many of the stakeholders in this room live, eat, and breathe daily. But it's also that, the benchmark methodology and all of the other things that go into the value equation that's really complicated.
The one I want to add that I think Farzad has already brought up is also the time horizon. In Medicare and Medicare Advantage, we are often dealing with a longer time horizon for improving that patient's quality of life and managing their overall health. If you look at the data for churn in the commercial patient population, how quickly does a patient leave their health plan? We're looking at 1.6 years on the long run. It is really hard to manage the life of a patient to improve their quality in 1.6 years at the population approach. It's much easier to do that if you've got them from 65 onward. It's so much harder in the commercial population because you might lose that patient after 1 year of them being in your health plan the next time open enrollment comes around. So that time horizon makes this so much more difficult from an incentive perspective as well.
Yeah. Okay, there are challenges, I hear. I understand
Just
that.
a couple.
But you guys have found success. There are strategies to get past those. And I know the audience and I would love to hear more about that. Wilson, do you want to kick us off?
One of the things, actually, thanks to NCQA measure sets, just having common standards, frankly, that many of the commercial payers, thanks to probably AHIP and NCQA for driving some of that alignment, have aligned to. I mean, one of the things we've done in this, again, giant grid of measures is try to align to, and I think I've shared this with some of you, is to three kind of core tenets in our across our markets. And it's one is, what's the population impact that these things actually make? And so, no offense to OMW, I can say that in this room and people know what I'm talking about, but osteoporosis management, right? It's an impactable measure, but the N size is so small compared to depression screening across 2.3 million lives in value and over 6 million lives in our medical homes that, we try to rank order that population health impact as number one. Number two is, what is that alignment across those 111 contracts so that we can prioritize the impact that our payers and CMS through the Medicare Shared Savings Program and others, or Medicaid programs, are incentivizing or driving us toward achievement. And then number 3 is the improvement opportunity. And so that's just a rubric that we've used to try to prioritize where we can focus our efforts. And then beyond that, again, I could probably talk about this all day, but what are the things that we actually need our physician partners to do versus the things that we can run in the background? I think I started saying this back when in my prior life in North Carolina, is that we can't just beat docs over the head and ask them to do more and to click more boxes and jump through more hoops, because that just means they're going to stop doing something else. So how do we really make it easier for them to do the right thing for the right patient at the right time? And some of that busy work we got to take off of their plates. And I know we've heard a lot about AI this week, and Dr. Pearl talked about. I'm hopeful that that even becomes more and more efficient over time.
Can I pick up on that?
Please.
No, that's perfect lead. And so we talk about the Aledade way when we talk about approaching problems, and it's got a kind of a pyramid where at the top of it, like we are at our best when we automate away the work. When computers can do the work, that's the highest value because they can work at scale. And so, we pull, and it takes a lot of effort, but we pull clinical data, we map it, we get it from all sorts of places, we consolidate into the patient view, and so now we can upload to the payer the actual blood pressure or A1C measurements, right? You don't need the CPT2 blah, blah, right? So that's great. We've automated a lot of that. We can send bidirectional text messages to patients instead of having to have the practice call them, whatever. So that's the top of the pyramid. The second row is enabling practices to do the work efficiently, and again, at scale, in a way that is with their workflows. So right now, the reality for a practice with a bunch of different payers is every payer says, go to my portal, and that's really hard. And if you look at the weekly logins from a practice into any payer portal, it's really, really low. We get 90% of the practices logging in every day. And that's because we combine all the work from all the different payers. There's one care gap work list. There's not 14 of them. There's one care gap work list that helps them, and it's prioritized, and we supplement it with information, right? So we make it really efficient for someone to go through those. And then when the patient actually is in front of the doctor, we give the doctor the key things that you should be thinking about and worrying about for that patient instead of them having to hunt and peck and look through charts. And then the third and final kind of component of that is centralizing what we uniquely can do at 10x more efficacy or better targeting. So we have a team of pharmacists who can find exactly the right patients to call at the right time and make sure that we can work on the medication adherence measures, which I would also say are overweighted, and we have way too much, like we're left with so few patients now that just a few patients are making a huge difference. And I think that's actually a conversation we all need to have around these topped out measures, and where, I mean, we are hearing every day with CMS stars ratings, like 2 calls, meant, whatever, $100 million. Seems weird.
Right.
Can I add, just my organization does not do the incredible work that yours does. We get to study it from the outside, and there's something I think very powerful about both of the things that you just said. I'm reminded of a quote. The best time to plant a tree was 20 years ago. The second best time is right now. You're dealing with some of the hardest work you can do in healthcare. You're not waiting for perfect systems, and you start. It's so easy to wait for perfect, but instead, one of the easiest ways to just overcome some of the great difficulty here is just start doing it and keep going. I will stop talking in just a second, but that reminds me of, I think, what I heard from the 10Care Medicaid value-based care example this morning. If you didn't get to attend that session, their risk stratification approach was it's not as perfect as they would like, but they realized, hey, we're going to keep using this because changing this algorithm, changing this approach would cause more harm than good. It might not be perfect, but we're going to keep going because even if it's not perfect, it's good enough for us to do the work. And I think that's just a theme I've been listening to in both of your comments and the great work that was shared earlier by the TenCare team.
We talk a lot about the transformation of systems, right, and how information is provided. But what about the transformation at the individual practitioner level? I'm gonna stick that on you, Farzad.
I think sometimes we attribute to resistance to change what is being overwhelmed and not knowing what to do. And I think there's actually, if we can, we call it scripting the moves and shrinking the steps. If we can actually say like, okay, like there's 1,000 things we could be talking to you about, but you know, we have the core 4, right? And it's like, oh, there's like, it's like there's a book, it's called the core 4, and it's like, well, it's everything about every version of primary care, advanced medical home, patient centered, like you've heard, is like the same 4 things basically. But we're like, no, it's the core 4, right? And we're going to start with number 1, access. And when we've done that, then we're going to start with number 2, care transitions, right? And you just march through and you make the change less daunting. And I think that takes care of a huge amount of it. And the other point is what Wilson said, is you can't throw it all on the clinician. You got to have a team-based approach and where everyone is helping do what they can best do instead of what a lot of electronic health records ended up doing, which is like the revenge of the ancillaries, like all the stuff that was like out and making other people's work hard now is fixed by making the clinician at the point of entry have to do all that. So let's try to resist that temptation.
Well, Daniel came and talked to our board of directors for our ACO in Illinois back in the spring, and we spent a half day talking about this. But, you know, I think it is also, we've got to see a change in clinician shortages, and, you know, we serve a significant underserved population in the south side of Chicago, and we have PCPs retiring at a much greater rate than we have PCPs that are willing to come work there. And it's, you know, going to be it already is, I think, almost at crisis levels, that if we don't solve this by creating, you know, team-based care models or leveraging some of the AI, I hope Dr. Pearl is right, and that these solutions are embedded, what do you say, in 90-some% of clinicians' offices in the next 5 years, because I do think there are so many opportunities to really transform the way that we do this care.
It was not at Wilson's presentation, but at a presentation at one point in time, I gave a conversation about demystifying value-based care. What actually is it? How does it actually work? And afterwards, a physician came up to me, and these conversations can sometimes feel very tense. I will admit I was a little bit clenched, being like, okay, he's going to challenge the very concept of value-based care. And I was very surprised when he said, I want you to help me figure out how to get there as fast as possible. And I think this is something that, you know, both of the organizations to my right would probably be able to demonstrate far better than I ever could. But in a world in which 49% of physicians are burnt out, a lot of the folks who actually practice in value-based models as physicians and advanced practice providers like it more than in this fee-for-service environment with value attached to the side. So there is something here where value-based care is not an opposite or a cause of burnout, but actually a potential balm for some of the burden that physicians in this country are carrying pretty heavily.
When I hear you all talk about trust and Farzad, when you say have people do what they do best, it makes me think about the relationships between payers and providers. Where does that come into play when you think about those partnerships? I've gone off script, I'm sorry if I was.
I think we talk a lot about foot in 2 canoes when it comes to practices and providers, but there's also a foot in 2 canoes for payers, where there's a, you know, like we were talking to one payer, and we were having trouble, and we went to the CEO, called me and said, well, you understand that the person you're talking to, their metric of success is the discount. That's like literally, they have, like, that's his metric of success, is how much of a discount he's getting on fee-for-service cost negotiations.
Right.
So there's no wonder you were having trouble with that.
Building
moving
trust.
that, right. But I think it is, if we are coming to a point, we're a self-insured employer, 1,500 employees, and I'm worried that our costs are going to go up double digits next year. If employers are not just going to keep saying, oh, sure, you know, like, sure, we'll pay 10% more. If there's going to be more pressure from employers, and I don't know if there will be, maybe there won't be. But if there is,
I think there will be. I think we've already started to see, as part of the Inflation Reduction Act and the CAA, employers are now fiduciarily responsible for their healthcare spend. And I'm already hearing tons of things from employers looking at 9% cost growth for 2026, 8.5% cost growth for 2025, and saying that I'm stuck between a rock and a hard place. I've got to do something, and I can get sued by my employees if I'm paying more for healthcare than I'm supposed to be, and I don't even know. They're going to have to do something. I think you're right on with that.
I'm curious, though, just by show of hands, how many folks are from payer organizations in the room? How many folks are from provider organizations? So, I mean, look around. Like, you've got a good mix of payers and providers. I mean, I've lived in population health for over a decade. I started working in pop health in 2013. I think I've been to the table with one employer with a payer partner.
It's telling.
So, you know, providers, you know, provider organizations, health systems that are doing value-based care should be the insurer's best advocate with your ASO clients, with your self-insured groups. I mean, we have, I think Advocate Health has 150,000 self-insured employees. And so, I mean, you know, the risk is real for us, and we understand, and again, we're working our value-based models to reduce the costs in our own employees just as much as we are in the Medicare shared savings programs or any of the commercial plans that we work with. But I really do think, Lori, you're touching on an important fact, and actually, I haven't seen that many provider folks, so it's good to see, you know, my brethren in the room. But just in the last day or so that I've been here, you know, it's a concern. And at NACOS, actually, you know, Aledade and Advocate are both very involved at the National Association for ACOs. And Anish mentioned it yesterday. He's been very involved there. You know, it's been a real absence of having payers in that room, quite frankly. And I think there's this, you know, payer-provider partnerships in this space are more critical than ever, especially under these challenging times. Because what I fear is if we don't figure out how to work together, then it's just all going to retreat back to the stability of fee-for-service.
I've got a terrible thing that I'm going to say.
Okay, moving on to the next one.
A great realtor will sell you a house, wait until you're ready to sell that house, and then come back with you and work to sell the next house and sell you the next house. That's a partnership. You go back to that realtor multiple times. You want to have a long-standing partnership. It's not about winning each dollar this time, to your point about the discount being the metric of incentive. A great realtor will want you to have a long-standing partnership with you so that you sell them your house and then they sell you the next house. If we do plan provider negotiations as if we're at the car dealership and it's about getting the lowest possible price for us or the highest possible price for them, whichever hat you're wearing, that's an adversarial relationship that you can't really call a partnership. You don't go back to the same car dealer for the most part. That's not something that we really do. And so if we are going to have a transformation in healthcare, we need to act less like we're selling cars and more like we're building long-standing realtor-client relationships.
Healthcare. Let's be as good as real estate brokers.
You got it.
For sale. Okay. playing off that a little bit, Daniel. So we hear about the defined value, right, as the outcomes that matter to patients and the cost to achieve those outcomes. So when we talk about it as an equation, value is quality divided by cost. Question is this the right equation, and where's patient experience in that equation?
No.
I think about cost and patient experience, and I think back to when I was a medical resident a long, long, long time ago, and I had a patient ask me, I wrote a prescription for a procedure, and she said, "How much is it going to cost?" And I remember with shame, and we all remember shame, right? When you feel ashamed about something, you remember it. I remember with shame that I said to her, "I don't know, like maybe the lady at the front desk can help you with that." But what I'm ashamed of isn't that I didn't know. What I'm ashamed of is I was proud. Because you see, I was doing evidence-based medicine without, like, I would not sully my hands with something as, dirty as money. I don't think about money. I just think about what's best for the patient based on the literature and blah, blah, blah. And that was, pardon my French, bullshit. Because that patient, because she was choosing between food and housing and the cost of that test.
That's right.
And so, no, I don't think we can morally say, oh, just focus on quality and let's not think about cost for us or for the patient. Sorry for being...
Yeah.
No, as far as I think it even goes in, I've been pulling on this thread a little more. We talked again a couple years ago about Switch and the elephant and the rider, right? And telling that different narrative that, controlling cost is also about doing no harm, in my opinion, of delivering care that aren't gonna put people in medical debt, right? And try to prevent them from having poor outcomes. So I think you're absolutely right. And I mean, I think there's a huge opportunity to translate better, and it's something that I don't think we've totally figured out. Happy to talk to someone if they have, but figuring out how to weave that thread is say, help them pick plans that, are the best benefit for the conditions that they have, or keep their out-of-pocket costs low and things of that nature.
I think as an industry, we are torn between two schools of thought when it comes to patient experience and value-based care and quality. One is we put the patient at the center, and then we do all of the things around them. We block for them. We have a care team. We have navigators. We are kind of guiding them through the system, and they might never know that they're in a particular type of contract. That's on us to own. The other school of thought is we empower the patient. We make them a part of the care team. We engage them in a way where they realize, okay, this is actually how I need to be acting because this is how my care is going to get paid for. It's much more about being accountable for their own care. But I don't think, and I would encourage anybody in this room, when you are doing a contract, when you're doing business, when you're thinking about a measure, is this something that puts the patient at the center, or is this something that makes the patient a part of the accountable care team? If we are doing both of them, we're not doing either of them.
Can I just come back to the one other thought is, I was showing my results, our results from our longest running cohort, and we have a 17% reduction in all-cause hospitalizations in that cohort in a diff and diff analysis. And someone said, yeah, but how about the quality of care? And I was like, 17% reduction in all-cause hospitalizations, that's not quality?
Sounds like good quality.
Right? And I think that this artificial divide we put between, oh, did you get your mammogram? The errors of omission versus commission, oh, it's okay if the person had like 12 ER visits and 3 hospitalizations, but we know we got the mammogram. Right? Like that to me is like sometimes a weird dichotomy. And I'm a big supporter of both patient-reported like net promoter score, right? Like, would you recommend your doctor? Like, people aren't stupid. You know, like if they say they would recommend, 90% of them would say they would recommend this doctor to a family member or friend, like that means something. And if we're keeping people out of the hospital, I think that means a lot, actually.
But I think one of the things we're seeing in patient experience, and you mentioned this on the medication adherence measures, for example, the stability and the waiting, especially in the Medicare STARS program, has changed drastically. I mean, just in the last 4 or 5 years. I think in 2020, patient experience made up 23% of the STARS rating. In 2023, it was 46% of the STAR rating. That's really challenging for organizations like ours that, again, I mentioned are serving South Chicago, where we have access issues because we can't recruit doctors there. Our patient, we're trying to pull out every trick that we can, but I also worry that there's some of this that we potentially are putting even more onus, on these areas. Like there's not a deprivation index adjustment for South Chicagoland whenever it comes to patient experience, nor am I sure that there needs to be, but it's really challenging, and I fear that we might cause inequity issues of having those high value plans pull out of markets because the stability of the models have shifted so dramatically over the last few years.
Yeah. So I'm confident we have some questions in the audience for this group. So if you have one, make your way over to one of the microphones. And while folks are lining up, I'm going to do the magic wand question. So if you could wave your magic wand, keep it in your back pocket for now, what is one change that you would make that would drive adoption of value-based care? Daniel.
Expelliarmus. I would go back to that point of if I could wave my magic wand when somebody's at that point of having those conversations and they are in that position just starting, right? Say, okay, we are going to judge this on a 5-year time frame, not a 1-year time frame, maybe even longer than 5 years, but just start and begin rather than waiting for all conditions to be perfect. I think that waving that one magic wand spell in that situation would be really powerful for progress.
I have a very weedy congressional ask. There's one thing we could do. People may recall the AAPM bonus, the advanced models, that it was supposed to spur a more adoption of alternative payment models. The problem is how they were designed, and they've now expired, and there's a lot of debate about whether we bring them back. And the way that they're designed is, if you join an alternative payment model, advanced alternative payment model, 2 years from now, you'll see like a 1.8% increase in your fee schedule. That is that is the worst behavioral economic design you could possibly imagine. I would say if you sign up in August, in January, you get, for every attributed person you have, you'll get $250. Like, there should be an upfront cash incentive for people entering the models that will drive, I would guess, 3-4 million more people into Medicare ACOs if they did that change.
Yeah, the cost doesn't wait 2 years.
Can I answer this question as an individual and not a representative of Advocate Health and off the record for any reporters in the room? I think mine is probably grandiose, and actually maybe even more grandiose than Farzad's. I think there has to be a disconnect between the fee-for-service and value models. Again, I mean, to Farzad's point, when you're talking about these tiny increases, although frankly, some of it really worked. The Medicare Advantage program, or Medicare Shared Savings Program, huge adoption amongst health systems like ours that saw the implications of that. But we haven't seen that in the commercial space for my friends in insurance in this room. And again, if we, I fear, again, if we don't figure out value as an industry and figure out how to do it to ourselves, the government will do it to us. And so, you know, if the magic, I don't know that the magic wand is like a Medicare for all solution, but I fear, frankly, you know, it's something of that nature that really drives more drastic innovation and a push toward value that we don't have today, especially in the commercial population.
Can I add one in the vein of my colleagues?
You get 3 wishes. Oh, no. sorry.
Yeah.
3 more wishes.
Can we wish for more wishes? I would, if I could wave a magic wand, I would see to it that we stopped creating models that were in conflict with one another. The one that's really top of mind for me from this year was the GUIDE model, which is all about dementia, was actually in conflict with the Medicare Shared Savings Program right up until the very end. And so doing well in the GUIDE model would have dinged you in the MSSP model, and doing well in MSSP would have dinged you in the GUIDE model. If we can do a better job of catching those things up front at design, rather than having to amend them years into the model, where those amendments actually create work for everybody involved, I think that would also drive adoption.
So much for that alignment, right? Okay. All right, we got a couple folks. Come on up to the microphone. Let us know who you are, please.
Hi, I'm Chris Anderson. I'm with NCQA. This is related to cost. I was wondering if more transparency and cost between payers and providers and everything would help push value-based care and make patients more receptible to getting the care that they need.
I have a great data set for you. The short version is price transparency, cost transparency. There's been a lot of work done on that, and what it's done is created visibility. It actually hasn't driven down costs. This is an article that came out, I think it was in Modern Healthcare or something earlier this week, and I think that that's one of the challenges. Just being able to see it is not sufficient if we're actually going to do this work. But that's what that article says. I'm curious what my colleagues think.
I actually think it would be really potentially helpful if price transparency increased costs. Stay with me. If you look at the payer price transparency data that came out, and if you figure out a way to parse through the terabytes of data, what you see is that there is a huge delta in what people are paid based on if they are independent practices or if they're part of health systems with a lot of market power. And so what happens is that then the independents go out of business, get bought by the bigger systems, and get paid 2 or 3 times as much, which in the dynamic world increases costs and then increases the market power of the dominant health system and then drives costs even more. Whereas just being able to say, like, gosh, you're paying this primary care practice 110% of Medicare, but if they go out of business or get bought by the health system, now they're at 200%, like, why are we doing that? So in a way, in the short term, I think if we show people, like we were showing this, one of the state employees, that their carrier was paying, this is unusual, but not unique, their carrier was paying independent primary care docs less than Medicare. And then they were wondering why they can't get primary care access. So I actually think there's an argument to be made that we actually need to increase some of that, you know, the discounts that guy got on those poor onesie twosies, right? Squeezing them isn't helping the system as a whole.
Thank you. Next question.
Hi, my name is Serena. I'm with Central California Alliance for Health. We're a managed Medi-Cal plan, and so we are heavily regulated, as is a lot of healthcare, by DHCS, which is the California agency that holds our contract. And so it occurred to me when you were talking about seats at the table and who needs to be involved, and we were talking about provider and payer. As a payer who is funded from the state, the government entities, our regulators also need to be involved. We have to get approval, for instance, to give out a $50 member incentive for someone to get a breast cancer screening. And that administrative burden is hits all of us in different ways because it's heavily regulated. And so I was just curious to hear the thoughts of the panel on government partners when it comes to quality.
I think it's incredibly important, and frankly, in some of my experience, Medicaid is the most lacking in innovation, and yet it's probably the most ripe for value-based care population out there.
Absolutely.
I think I was a WIC kid. Whenever I was born, right? My mom. I had a twin sister, and anyway, we were on WIC. And so I think about, and it's kind of heartbreaking, honestly, to me, whenever I see our contracts that, frankly, our data is so poor from our major Medicaid partners who cannot get us consistent data on a monthly basis, despite having over 110,000 members in one plan with them and having been in a relationship with them for years and years and years. There's very little collaboration, I think, for the government partners. So I think there's huge opportunities. I think we're really doubling down at Advocate to kind of focus more innovation in this space. Luckily, North Carolina, actually, in my sabbatical from living in North Carolina over the last 4 years, passed Medicaid expansion, thankfully, and increased access to 100,000, I don't even remember, but tens of thousands, hundreds of thousands of individuals. And again, I just think there's huge opportunity. But even in those plans, there's still a disconnect on, you might get a care management fee, but there's no tie to shared savings, and there may not be a tie to quality.
And I guess I would say, as long as you're having the burden on the regulations, at the least that we could do as government policymakers is ensure some standardization so that we're not reinventing the wheel with every MCO contract that we have.
We're out of time, but caution to the wind here. One last question.
Oh, okay. Pressure. So I'm Dr. Zahid Bhatt with Medisolve. We're a quality measures vendor. First of all, compliments to Dr. Mastashari for doing such a great job for independent primary physicians in this country who are under a lot of pressure from many different directions. But my question is, we've heard so much about all the multiple sort of value-based contracts not aligned with each other. What is the barrier to have this multi-payer ACO concept, which exists but hasn't really taken off the way I see it? What are the barriers from the commercial payers to align and harmonize with MSSP as a multi-payer ACO?
I mean, I think it's a great question, and one of the things that immediately comes up is like, well, different payers can't talk to each other and standard, right? There's like antitrust stuff, but the answer is what you just said, is why can't they harmonize with the Medicare Shared Savings Program? There's nothing, that is actually a great role for government, is to not just be the convener, but to say, everyone can use that model. Everyone uses the same, whatever, HCC model or whatever. Why not use the same quality measures? Why not use the same benchmarking approach? I think that would make a ton of sense.
Yeah, I mean, we were talking about this earlier too. I mean, even if it was as simple as using the ACA model as a consistent model that's public source and not some black box secret, voodoo magic, and aligning with the ratcheting effect, like you mentioned earlier, I think those key principles in value-based care and commercial, like if our commercial AHIP, again, if you're in the room, help us drive that, I think would drive adoption so much more significantly in both independent practice models and system models.
I look at Blue Cross Blue Shield of Massachusetts for an example on this one, kind of the idea of this alignment. The provider leader of WellForce, which is this big clinically integrated network of both employed and independent physicians in Massachusetts, went to the plan and said, you're killing us. We've got way too many measures. Let's get it all down to a simple, streamlined amount. For the entirety of the state, Blue Cross Blue Shield of Massachusetts uses 10 primary care measures with the same data, and they've aligned it across all payers across the state. If we could just get that kind of simplistic, that simple collaboration and simplicity across various stakeholders, a lot more is possible.
Gentlemen, you did not disappoint. Please join me in thanking.
And our moderator.
Thank you, thank you. All very, very important. Women in Quality reception is this evening. Everyone is invited. We hope to see you all there. Thank you for joining.
The heart is a balloon, shoots up through the stony ground. There's no room, no space to rent in this town. You're out of luck, and the reason that you had to care, the traffic is stuck, and you're not moving anywhere. You thought you found a friend to take you out of this place, someone